Welcome back to the Dr. Geo Prostate Podcast. Can high-precision radiation change how we treat metastatic prostate cancer? For men with cancer that's spread to bones, lymph nodes, or other tissues, Stereotactic Body Radiation Therapy, SBRT, offers a new approach: fewer sessions, targeted treatment, and the potential to preserve quality of life. But how well does it work, and who benefits most? Today's guest is Dr. Ron Chen, a leading expert in prostate and bladder cancer. He's authored national treatment guidelines for the American Urological Association and the American Society of Clinical Oncology. He's published over 170 studies and leads major clinical trials shaping the future of cancer care. In this episode, we explore where SBRT is most effective, its limits, and how it could transform outcomes for men facing advanced prostate cancer. Let's dive in.
Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Geo Prostate Podcast. I'm your host, Dr. Geo, and it is my intention and my goal to optimize the quality of information as it relates to your prostate health, all things prostate cancer, testosterone, and how to live well, really well, with age. My guest today, Dr. Ron Chen. Ron, thanks so much for being on.
Hey, good to see you, Gio. Happy to be here.
We started talking about a couple of years ago. You threw the first pitch at a Kansas City Royals game. We're big baseball fans here, so we talk about that for the next hour. Talk baseball. I would assume that, however, that my audience is probably not as interested in that. So we'll move on that. But that was a good experience, as you said.
Incredible. And just very quickly, I don't think I didn't know this. The mound is actually elevated off the ground. So if, as a pitcher, if you threw straight, it will actually fly over and make you look like a fool. So I had to practice throwing down, which is a good thing I knew about that.
So did you practice on a mound that was elevated, which they all are? Was that, or did you practice in a flat surface?
Well, I drove around Kansas City looking for several open community baseball fields, looking for an elevated mound. They were all flat, and I drove for a whole day. So I practiced flat, but mentally, I had to adjust down when I threw the real pitch.
Wow. And did you hit the target? I'm not even going to ask you if you hit a strike because that's irrelevant. Did you hit the target?
It was video recorded. I threw it from the real mound. So the full distance. It was a strike.
A strike.
A strike.
Nice.
It was strike.
Nice. And it was I think it was prostate cancer night or something like that, or another prostate cancer awareness.
Yeah, I love the Kansas City Royals. I grew up in this area, and in recent years, the Royals have had either a men's health or a prostate cancer awareness night every season in the past several years. Really awareness of the importance of prostate cancer screening, detection, treatment for our community. It's really great for the Royals organization to be able to do that.
Ron, I didn't know that you grew up in Kansas City. I thought you just lived there because that's where your employment is at Kansas City, Kansas City University. Are you a Jayhawk as well?
Absolutely a Jayhawk. I grew up in Kansas. And of course, Kansas City is an incredible place to live and raise a family and treat patients. But yes, I am absolute Jayhawk, Royals fan, Chiefs fan, everything Kansas City.
I'm surprised in your background that you don't have a Jayhawk or a Kansas City Chiefs logo or anything like that. What's going on?
Well, first of all, I will point you and the viewers to a picture that you see on the sort of this side right there.
Yeah.
That is me wearing a Royals jersey on the night one of the nights where I was at the game. And actually, the jersey, the name on the back is Chen, because the Royals actually had a pitcher named Chen playing for the team several years ago. So I was able to get a jersey with my same last name, which is really cool to be at a Royals game wearing a jersey with my last name on it. I do have Royals
Nice.
gear,
Yeah.
and what you don't see on the camera is I actually have also a Chiefs. Look at that Chiefs
Ah, there
poster
it
with me at
is.
the
There
front
it
and
is.
a bunch of the starting players on that. So yes, indeed, I have that all over my office.
And you have to have a Patrick Mahomes jersey. You have to.
I don't actually have a Mahomes jersey, but I do have a signed jersey from one of the linemen actually. And
Oh, nice.
I have a Mahomes signed hat actually. So a
Oh,
couple of pieces.
nice. Well, that's great to know. Again, I knew about your professional life at KU as a radiation oncologist, not so much that you grew up there. So you're back home. You're working home.
Absolutely. Yep. Back home, serving the community here where I grew up. It's really meaningful here.
Lovely, lovely. Great place. I took my son to a Kansas City Royals game, as you know, about a month ago or so. And it was just so much fun. So much fun. Talking baseball, a lot of Case Royals fan. And my son had a great time. He's a baseball fanatic. So it was a lot of fun. Ron, I thought that we have several recordings with other experts, right? So John Haas, Michael Zalewski, Nima Ahmed. And so I think we've gone through pretty thoroughly the different forms of radiation, what different forms are probably best suited for prostate cancer, how to apply androgen deprivation therapy, why do that. One of the things that we have not spoken about in any length is what happens when there's a recurrence.
Yeah.
So just today, I saw a patient, he's 62 years old, and in his case, he did proton beam radiation. Actually, he's 72. He did proton beam radiation, and it recurred. His PSA now is in the 200s. And there's evidence from a PSMA scan of several metastases to several areas: pelvic bone, L4, one of the vertebrae, and the hilar node. Okay? So it's 3 areas. And I said, well, go see. I gave him a recommendation, one of our radiation oncologists, and hopefully they can target each area. So I guess we can talk about the different recurrence situations and what to do from a radiation perspective. The first is when there's only evidence of recurrence in one of the pelvic nodes, right? So it's just, let's say they either treat it locally with whatever treatment, and then there's a recurrence where now one of the pelvic nodes near the prostate, or where the prostate was, if it was removed, there seems to be evidence that there's a node there. The first question is, and I did have a radiologist come on and talk about PSMA scans. Is there SUV max that where you would say, so SUV max, if the listener can go back to my conversation with Dr. Herbert Vargas on PSMA PET scans. And my takeaway was that anything below 5 in an SUV max is, we're not sure. We kind of leave it alone. And if it's above 5, then it's very likely that there's cancer related. Is there an SUV max that you say, do you look at it that way? Or even if it's an SUV max of, let's say, 2, you would treat a local recurrence, at least in this?
I think for your listeners, it's hard to have an absolute SU number above or below where we think there's likely cancer or not cancer. I think part of the reason it's hard to sort of tell a general audience that there's a cutoff of 5 or 3 or 2 is because the SUV is dependent on exactly which PSMA PET agent you use. And so every hospital may use a different PSMA PET agent. And it's based a little bit on technique and timing as well of the scan. So the SUV cutoff or guide for a cutoff is institutional dependent based on the agent and the timing and the technique. Dr. Vargas at his institution may have a cutoff of 5. At mine, we may use a different agent, so it may be different. So I think that's important. But I would also say, similarly, I think as you said, there's different scenarios for a recurrence after treatment. So you could have recurrence after surgery, you can have recurrence after radiation. Actually, and I think the different scenarios for recurrence, Actually, probably the earliest scenario for recurrence is if there is recurrence in the prostate before it even goes to lymph nodes. And then I guess a little bit later than that, there could be recurrence in the lymph nodes, which would be a different situation. And then later than that, it could be recurrence where it has metastasized to the bones or other things. So I think to me, those are probably the three distinct states. I do think it's important, whatever primary treatment a patient has, whether it's surgery or radiation, continue close follow-up so that if there were recurrence or rising PSA, being able to get a scan, PSMA PET, for example, at a pretty low PSA, maybe when the PSA goes to 1 or 2 or 3, if we can catch a recurrence when it's still localized in the prostate, there's actually a lot of treatment options in that situation to still try to cure the patient.
Thank you for clarifying, which is a great point. I never think of prostate cancer recurrence in the prostate outside of focal therapy. So it is possible that you radiate the pelvic area and the prostate, and there still can be recurrence of the prostate itself, and then you can retreat that with radiation. Is that correct or no?
Yeah, I think that's right. And actually, I think this is really important information for your listeners. When I see a patient who has newly diagnosed prostate cancer, who is trying to decide whether to go the surgery route to remove the prostate or radiation, because those are the two primary treatments for prostate cancer treatment. A lot of patients who I see who are thinking about radiation, they have the impression that once you radiate the prostate, if there is a recurrence, it's going to be much harder to treat. And in fact, it is true that even though surgery and radiation are both very effective, for the patients who recur, if it happens to recur in the prostate, maybe 10, 15 years ago, there weren't very many options for those patients who recur after radiation in the prostate. You could always remove the prostate after radiation, but it's a much harder surgery,
Right.
and a lot of centers don't do that. But over the last 10 years or so, those patients who may have a recurrence in the prostate after radiation now have multiple options to salvage a recurrence in the prostate. Not that the recurrence in the prostate is a very high rate, but in the limited patients who have recurrence in the prostate after radiation, there are actually now multiple options to treat the prostate again. For example, and actually, in the prostate, if there were a recurrence, and usually it's a recurrence maybe in a spot or a couple of spots, so here are the salvage options to treat a prostate again. You could treat the prostate with brachytherapy or seeds. It's actually, there's a spot in the prostate where there's a recurrence after prior radiation, you can actually just put a few radiation seeds where the recurrence is in the prostate, and that could actually have a very effective long-term and potentially cure rate for this patient a second chance. So brachytherapy is one option. Another option is HIFU. Some people think of HIFU as a first treatment option. It could also be a second treatment option. HIFU is especially great if the recurrence in the prostate happens in one location. And so HIFU will be a second way to salvage a patient after radiation treatment.
So
Cryos,
HIFU, for the audience, and we've had several
yep,
episodes on focal, is high intensity focal ultrasound, where the practitioner attempts to really treat the tumors focally around the area of the tumor.
exactly right. And whereas you can do that when a patient's first diagnosed, you can also do focused treatment if there's a focal recurrence in the prostate. And so HIFU would be another salvage option for radiation. Cryotherapy, which is
Sure.
freezing the prostate, is another salvage treatment to the prostate after radiation. You can also, now there's SBRT. I'm sure you talked about SBRT as a primary treatment option, but SBRT can also sort of do either focal treatment for recurrence or treat the entire prostate as a second round of radiation. And as a fifth option, you could remove the prostate after radiation, although it's harder. So now, over the last 10 years, I am now able to offer patients 5 options to salvage if they have primary radiation, happen to have a recurrence in the prostate. And in fact, so that really offers patients hope for a second chance for cure if the recurrence is caught early.
The only time I've seen recurrence that's localized in the prostate after radiation is after proton beam radiation. So I've never seen it after any other type of radiation. Do you see? Because to me, it's like you're radiating the whole prostate, whether it's 44 treatment or 25 or SBRT 5 treatment. Have you seen it? And why would that happen if you're radiating that area? Why would a recurrence that's local happen?
Yeah, that's a really good question. There is definitely local recurrence after radiation. Using the same analogy, there's local recurrence after prostatectomy. You can ask the same question. If you remove the whole prostate, how could there be a local recurrence? Well, it's because sometimes the surgery misses a little bit and leaves a little bit of cancer behind. So after surgery, you can have a recurrence and you hope to catch it early when it's still local. And after radiation, whether it's proton therapy or SBRT or SEED or all the other forms of radiation, there can also be local recurrence because maybe a little bit of cancer survives in a spot of the prostate, maybe it's the especially aggressive type. And again, the goal is to monitor patients closely after primary treatment, surgery, radiation, follow them closely. And if there's any indication that the PSA is rising, showing something's not right, catch it early, treat it when it's still local, and try to cure the patient a second time.
Beautiful.
Now that we are able to offer all these options to patients who've had radiation, my center, and we do a lot of this, we're getting more and more salvage referrals because we have that expertise and we're able to offer these options. And so instead of, again, 10 years ago, if patients had a recurrence after radiation, it's either hormone therapy or prostatectomy, which is not great as a second treatment.
Prolon is the only nutrition program patented to support longevity, health span, and protect lean body mass through cellular rejuvenation. This 5-day fasting mimicking diet keeps your body in a fasting state while allowing you to eat nourishing foods. Over 5 days, your body is rejuvenated at the cellular level, supporting fat loss with muscle protection, boosting energy and mental clarity, and giving you a complete body reset. Your kit includes everything you need for the full 5-day transformation. Click the link in the description to learn more and see our partner pricing.
Now we have all these other options for patients to think about.
Yeah, the analogy, I don't know if you've heard this analogy before, surgery after radiation, is that if I give you a cold grilled cheese and I say, hey, Ron, can you remove the cheese for me? You say, yeah, sure. If I give you a grilled cheese, I say, Ron, can you remove the cheese? It's a little stickier and a tougher situation.
No, that is absolutely correct. To remove the prostate after radiation therapy definitely is a harder surgery. If we were to do that, I would refer a patient to a high volume place that does a lot of salvage prostatectomies, and that is an option. But now I can tell patients there's at least 4 other options after radiation before we have to do a sticky surgery.
Right. All right. So let's say now there is a recurrence and it's only in the pelvic nodes.
Yep.
What I would like if I'm the patient is, hey, can you just treat these nodes and leave my healthy tissue alone? How many nodes need to be? Is there a maximum amount of nodes that need to be positive for you to say, no, we have to treat the whole area? Because let's say you found 5 nodes, it's just might as well treat the whole area. Or do you treat each individual node with a beam that hits just those nodes? Is that an option?
Yeah, that's a really great question. And what you mentioned is if a patient has a recurrence in the lymph nodes, one approach would be to use radiation to treat all the lymph nodes, and in fact, on both sides of the body. Another approach would be just to use very focused radiation like SBRT to just treat the individual small nodes that we see on the scan. Those are 2 opposing approaches.
Is there a maximum number to do SBRT?
There's no right answer. There's no right answer. And so ideally, we would have a clinical trial to compare those approaches. That would provide the evidence on which is more effective and how we select patients for what. We don't have that kind of clinical trial comparison. So what I do, it's more philosophical when I have this conversation with patients.
Yeah.
Even if they only have one node, and I think you would probably agree with this. I think a lot of your listeners will agree with this. It's about assessing the patient's priorities and of different approaches. I think even if the patient has 1 node recurrence versus 3 nodes versus 5 nodes, when there's a recurrence in the lymph node, the fact is that is already metastatic disease. The cancer has left the prostate and gone to the next station. So it already is metastatic prostate cancer. Whether it's 1 node or 3 nodes or 5 nodes, that is a fact. And so what is unknown, what is also known is that nodal recurrence is still potentially curable. When I say cure, you can still potentially treat it and completely wipe out the cancer forever and ever and ever. It is still potentially curable. But I think it's important. So the most aggressive approach, so if I have a patient who says, give me everything you got, throw all the weapons at this, and I want to be as aggressive as possible, the approach for a no positive prostate cancer, the most aggressive approach would be radiation to both sides, including that one lymph node that may be sort of where the recurrence is known to be. You would also give hormone therapy and potentially something like abiraterone on top of that, because abiraterone in some clinical trials have been shown to improve survival for no positive prostate cancer. That would be the most aggressive approach. Some patients will be like, whoa, 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 abiraterone can cause hypertension.
They'll chat GPT abiraterone, and they're not going to be happy with the
That's
side effects that they're going to.
Yeah, abiraterone has side effects. It comes with prednisone,
Yeah.
and you're adding that to hormone therapy, which can impact my muscle mass, sexual function, perhaps
Mood.
cardiac, and you're going to treat both sides of my lymph nodes, and there's some bowel in that area. I don't want to be that aggressive because that doesn't sound like a lot of fun. What's the least approach that protects my quality of life and still could have efficacy? So the other extreme would just be SBRT, which is very focused high dose radiation to that one lymph node, those 2 lymph nodes. No hormones, no abiraterone, no treating all lymph nodes on both sides. That's the range of standard of care. And where in that range of standard of care makes a patient live the longest? I don't know. Nobody knows. We don't have a clinical trial on that. And so a patient's preferences and how aggressive they want to be and what quality of life components are important to them is a central part of this conversation.
It has to be a tough sell to say, hey, I'll treat your whole pelvic area for this one node that you have positive. I'll treat your whole pelvic area, hit a lot of healthy tissue. Oh, and by the way, you're going to be on very aggressive anti-androgens as well. That's that's
Yeah.
a tough sell.
Well, I think different patients have different mindsets.
Right.
It's a little bit like, as a radiation oncologist, we do treat many different cancers. I specialize in prostate cancer, but if I use a breast cancer example, there are breast cancer patients who will take aggressive chemotherapy for a 1% improvement in survival. 1% for chemotherapy. Some patients would, some patients would not. And going back to prostate cancer, some patients go, give me everything you got, doc. And the rationale for being aggressive for patients who have no positive prostate cancer, the rationale for being aggressive is we know that even if the scan only sees one node, a lot of the patients where the scan sees one node have microscopic undetected disease elsewhere in the body.
Sure.
And that's where the hormone therapy and the abiraterone may target.
Sure. But in an age of, and I know it's not perfect, God, these PSMA PET scans are really darn good. I mean, I always say, if you have to have a cancer, prostate cancer is probably the one you want to have. And if you want to have it at any time in the history of time, you want to have it in 2025 with the great biopsies, targeted biopsy, PSMA scans. And you're right, it doesn't detect, but it really detects very small cancers better than any any imaging that we've had in the future.
For sure, PSMA PET scans, which has only been available for a small number of years,
Yeah.
have been a game changer.
Yeah.
Before PSMA PET scans, the best we had were CT, MRI, and bone scan. PSMA PET scan beats those by a whole mile, detecting small amounts of prostate cancer that we couldn't see before. It is still not perfect, and I bet in 10 years we'll have a next generation of scans that'll be even better. But it is really good, yes.
In 2025, I do suggest my patients, because they see me, so for context, they see me for two things. Number one, as you know, I'm a holistic and integrative doctor. So, how do I eat? How do I live? How do I exercise? What supplements to take, what not to take? Those kinds of things. And it's very prescriptive. The other hand, they see me for, hey, help me navigate this. This is so confusing. And I'm oftentimes saying, no, hit that one node. And depending on what their original pathology was, how aggressive it was, then I would say yay or nay as it relates to anti-androgens. And if it is an anti-androgen that I would recommend at this moment in time, it's Relugolix or Orgovix, just because the side effect profile is low. I do understand the research with abiraterone, but man, that's a tough one. And patients, they get a hit. They get their quality of life takes a hit. I have to say, a patient I had today, he was great. He went through abiraterone, Lupron, and 44 treatments of radiation and an anomaly. Looked great, felt great. So every now and then you're like, this is a case study. Why do you feel so great? Meanwhile, the last two patients I saw prior to that, it's like, God, they're like, I don't want to ever do this again. I'd rather, die from prostate cancer. So it depends.
Yeah, I agree. I want to speak to this sort of SBRT to this one lymph node option. And again, I have a conversation about this range with patients and sort of assess where they're at and what their priorities are. If a patient has, you probably used this term on your prior episodes before, oligometastasis. Oligometastasis, let's say in prostate cancer, when prostate cancer has spread to a limited number of nodes or spots, 1, 2, 3, 4, 5, limited number of spots, oligometastasis, there actually is good clinical trial data to show that for patients who only have a small number of recurrences, let's say 1 node or 3 nodes or 4 spots or whatever, we could do SBRT to those limited number of spots with no other treatment, no hormone therapy, nothing else, just like what you were saying. And when we do this and just the SBRT to those small spots, on average, that could control the disease without any further recurrence. On average, can control it for 2 years or more. So if we did this to 100 patients, just doing the SBRT to those spots and nothing else, half of those patients may have no recurrence after that for 2 years or more, no hormone therapy. And for many patients, that seems pretty good.
So how would you get it for it to be no recurrence for 5 or 10 years or ever? Are you suggesting that maybe if there is hormone therapy combined with the SBRT that they can extend that? Because 2 years doesn't sound like a whole lot. That doesn't sound like a lot of time.
2 years with no
Hormone
more
therapy.
disease, with no more disease. And so let's say on average, you can get through 2 years with no more disease for half the patients. That means half the patients are able to do longer than that.
Right.
Let's say after that, there is another spot that pops up or 2 more spots that pop up. At that point, you can decide, do I just SBRT that other spot and 2? And then
is there a limit? So another spot 2 years later, another node, another spot bone, another spot 10 years later, L4 vertebrae. Is there a limit or not really?
There's not necessarily a limit to how many times you can give radiation treatment. The limit of radiation treatment is based on treating the same part of the body more than once. And so, for example, if you happen to you've had radiation to L4 before, and a year later, you have to treat L4 again with radiation, treating the exact same area with radiation more than once can increase side effects to that area. It's possible, but we have to be more careful. Treating the same area a third time, probably not. Probably that exceeds the dose tolerance to that part of the body. So that's the limit. So, but if you're treating the shoulder, a lymph node on the left, a lymph node on the right, the prostate, different parts of the body, there's really not a limit to radiation treatment.
Great. however many nodes in the pelvic area. We're going to stick to the pelvic area for now. How many? So when the person gets SBRT for the prostate, is 5 treatments. Though they're researching to try to make it less than that, as you might know. If we could do it in 5, can we do it in 2? But that's still under investigation. How many treatments per node does it require? So the patient's coming in, how many days do they need to come in to get treated?
Yeah, very good. In fact, going to your comment about SBRT through the prostate, it's 5. Could it be fewer? My team is about to submit our clinical trial of 2. We're done with that clinical trial. We're about to submit it to a journal in the next week. So
Okay, so
yes, I know that very well.
So you can tell us. Don't hold us in suspense here, Ron. What is do you know the outcome and the conclusion of that and of that study that you're submitting?
Well, I think there's other clinical trials that are ongoing, but I would say that a 2-treatment SBRT for newly diagnosed prostate cancer, there is promise that is safe and effective
Despite of Gleason score?
For I think early stage patients, probably Gleason 6 or 7 perhaps. Whether SBRT even 5 fractions, for high risk cancer, where is Gleason 8, 9, or 10, whether SBRT for high risk cancer is as good as longer radiation treatments, that is still being actively researched. And in fact, there's a national trial, NRG-GU013, that is looking at SBRT for high risk cancer. And it's a very large trial. I think that will really help us get the answer.
Yeah.
For low and intermediate risk, SBRT is as good as anything else. 5 fractions, actually 4 fractions is very standard as well. 2 fractions, 2 treatments, which is incredible, I think seems promising. And I hope that the clinical trial we're about to publish will add to the existing data on that approach.
Well, I can't wait. And I will let my audience know about it in one way or another. Maybe we'll have you back. Who knows?
Yeah. SBRT for lymph nodes. So if a patient has, let's say, as the topic is a recurrence in the pelvis, say a node or 2 or 3, and if we were to use the SBRT approach to treat the node that have recurred in the pelvis. Well, I think the general accepted practice is SBRT for any part of the body, prostate, lymph nodes, bone. SBRT by definition is usually 5 treatments or less. So if it were a node in the pelvis and we're using SBRT to very precisely treat that lymph node, it's by definition 5 treatments or less. Maybe it's 3, maybe it's 4, maybe it's 5, somewhere in that range.
How do you decide? I could tell patients love you, but they don't want to see you for 5 days if they don't have to. They'd rather see you for 2 days, and so that you could do the treatment in 2 days and not 5.
Yeah.
So how do you decide?
Well, I think that a lot of it, so I think your audience already knows this, but radiation is designed for each person's body and anatomy.
Mm-hmm.
We're all shaped differently. We have different organs, different organ shapes and where they are in the body and all of that. And so the exact number of treatments for each patient depends on the anatomy. And in the pelvic area where the lymph nodes are, it's amazing because I design radiation for prostate cancer all the time. That's what I do every single day. That's my clinical job.
That's your life.
That's my life. And I have patients who I have to treat a lymph node in the pelvis where here's a lymph node and there's just small bowel all over the place next to that lymph node. If that's the case, and I want to be gentle on the small bowel but still treat this lymph node, I may have to give it 5 treatments because I want to be gentler. 5 treatment means I'm using a lower dose per treatment. I'm sort of being gentle, stretching the dose out over 5, so it's gentle each day because I'm concerned about how much organ that's really close, and I don't want to damage that. I have also seen patients where I'm treating the pelvis and the lymph node where, oh my God, there's absolutely no bowel next to the lymph node at all. It's in perfect position. The patient has perfect anatomy. There is absolutely no bowel nearby. In that case, I can treat it faster with a higher dose per day and get essentially the same dose squeeze it into 3 treatments, but higher dose per day, because there's no organ for me to damage nearby. So it's really based on patient anatomy for me.
And what's adjacent to the area of interest, right?
Right. If it's a lymph node that I'm targeting, radiation treatment, SBRT, CyberKnife, I think your listeners have heard about.
Great marketing.
Great marketing. But CyberKnife or other forms of SBRT,
Yeah.
very, very precise. If I treat
Yeah.
a lymph node,
Yeah.
you can see, if you look at the radiation plan, we can hit that lymph node with the dose fall off after a lymph node is very quick. So we're treating a very small area, but some patients just have anatomy where the bowel is just right on it,
Right.
and we have to go slower.
Just for the audience, because they probably say, well, why are they talking about marketing? I mean, they already have trust issues with you guys, so I don't want to give that illusion. The reason why I said great marketing is because CyberKnife is actually a brand name, is not the name of the treatment. The name of the treatment is SBRT, but everybody knows it as CyberKnife. So it's amazing. It's like saying Kleenex, right? As opposed to tissue paper. So,
That's right.
But there's different forms and different companies that make such equipment for SBRT. So that was what that comment was about. All right, pelvic bone. Same scenario, I have to assume. I think you made that clear. Well, we could hit it with SBRT. Is there a situation where there's a recurrence in the pelvic bone where you wouldn't treat with SBRT, and why would that be?
I think it partly depends on the size of the bone metastasis. I like SBRT to treat a lot of different situations: the prostate, the lymph nodes, the pelvic bone, if there's a metastasis. SBRT I like because it's a short amount of treatment, so it's convenient to the patient.
Mm-hmm.
It's highly focused, so very, very focused, so very precise, and minimizes dose to surrounding tissue. And the high dose we use per fraction is also potentially more effective at killing the cancer in that area. So I like SBRT for a lot of different reasons. So if there were a pelvic bone metastasis from prostate cancer, my primary option is going to be SBRT. To your question of when I wouldn't choose SBRT, if the metastasis is huge.
Is there a number you have in mind above?
I don't mean number, I mean size.
Yeah.
So for example, if let's say it's in the femoral head, so sort of the hip of the patient, and let's say it is most of the femoral head is metastasis that I have to treat. What I'm worried about when I treat a large part of a bone with a large dose like SBRT is the possibility of fracture. And so again,
fracture induced by the cancer or induced by the radiation?
Both. And I'll explain that in a bit, because that's a really, really insightful question, and I'll explain in a bit. But what I want to emphasize for people who don't have prostate cancer, for men who are over the age of 50, screening, early detection, if you have cancer, catch it as late as possible, is the message. It's the same message after treatment. If you've had prostate cancer and you have surgery or radiation, continue surveillance, continue monitoring, and if you have a recurrence, catch it early is the same message, because if you catch it early, you can still potentially cure. And if it has metastasis to the bone, catch it before it grows big. So I can use SBRT, which is the most effective option. That is a key message. Now, to your question, if the bone metastasis is huge and I use SBRT and there's a possibility for fracture, is that fracture caused by the treatment or the tumor or both? Probably both, but here's why. As your listeners know, the bone is a very hard object, and when you have tumor replacing the bone, if part of the bone is now tumor is softer than the actual bone. So if you have a hard bone and it's now mostly soft tumor, that already is likely to break because it's no longer as hard as bone is. So just by having a big old tumor in the bone, it could naturally break even without any treatment. Can adding a large dose of radiation make the bone even weaker? Yes, that's possible. So it could add to the fracture risk. Another reason that treatment can add to the fracture risk is that if you treat it and the tumor shrinks too quickly, so that the part of the bone which is already kind of soft replaced by tumor, the tumor shrinks away and the bone has even less stuff in it, it could also fracture. So having very effective treatment that shrinks the tumor too fast can also cause a fracture. So all those things could be at play. But catching a bone metastasis before it's huge is the key.
Do you order a DEXA scan to these patients to see the health of their bones before you treat them with radiation, or at least to know what dosage to use?
In my practice, we always get a bone density scan if we're thinking about using hormone therapy, ADT, for patients. We want to get the patient's baseline bone density before we start ADT. And if they already have osteoporosis, we've got to do additional things to prevent further bone loss on ADT. And when they're on ADT, we monitor it on a periodic basis to make sure that they haven't had significant bone loss. So that's where we use it. When a patient has bone metastasis, we can usually see how much of the bone it involves in that particular part of the body by CT MRI to look at that particular bone where the tumor is. And that's really probably the best assessment that we usually make.
All right. So the other common area is the vertebrae, and the L's. Oftentimes, let's say I just saw a patient today, again, L4. Will the conversation change as it relates to bone metastasis that you would hit with SBRT relative to the pelvic bone, or is it pretty much the same thing?
Yeah, I think if a prostate cancer patient has metastasis to the spine, primary treatment option would usually still be SBRT. Very precise, very high dose, highly effective.
I mean,
And
the pelvic bone is pretty large relative to the vertebrae. So I think it's pretty remarkable that you could hit this little bone that's relative to the vertebrae and be so precise. I think that technology has improved quite a bit throughout the years, I have to assume.
yeah, incredible. Absolutely right. I think one of the things that's really important about the spine, and again, catch it before it gets too big, but one of the important structures that runs along the spine is the spinal cord, all these important nerves along the spinal cord. And SBRT can now give a high dose to the bone, even when it surrounds the spinal cord, and limit the dose to the spinal cord. SBRT can sort of wrap around dose to the bone and minimize the spinal cord. Really great technology we have these days for patients.
So the idea of hitting, you're completely right. The spinal cord sort of controls the movement and function of most of your body in one way or another, depending on where, from the cervical down to the lumbar or sacrum. So SBRT does a really good job in 2025 with avoiding hitting the spinal cord. You haven't seen that.
I mean, the ability for SBRT to treat metastasis in the spine and minimize dose of spinal cord to a safe level and really minimize the damage to the nose nerves. We're able to do that in 2025 in a pretty incredible way.
All right. So then let's move. So the other popular area where prostate cancer likes to travel to is the scapula, right? So that's sort of shoulder area in the back. Same scenario. We hit it, not too different than the pelvic bone, I would assume. Is that correct?
Yeah, I think that's right. I think the concept is the same. I like SBRT in that situation too. Now, I would say our earlier conversation, kind of started with what if there's a recurrence in one lymph node or a couple of lymph nodes. And now our conversation is if there's a recurrence and metastasis to a bone, whether it's a pelvic bone or spine or scapula. I would say that for the patient where there's now cancer spread to a bone, that is clearly metastatic disease. And when I have a conversation with the patient, and if they really want to say, hey, doc, can you just give me SBRT and I want to avoid hormones? That is still an option for these patients with bony metastasis. But the conversation and the realistic expectations change a little bit. Once it's metastatic and has gone to the bones, I usually tell patients, yep, we absolutely can start with SBRT to this bone spot and to that bone spot. And we can hold off hormones for a while. Hold off the relugolix, hold off the Lupron, and let's see how, and we'll follow you closely after SBRT, with scans and PSAs and all of that. How long it will be until more disease show up, whether it's 6 months, a year, 2 years, 3 years. There is variation, but at some point there probably will be more disease that shows up. And at some point, hormone therapy will probably be part of the future treatment for that patient.
Isn't it? And I haven't gotten a really good answer from anyone because I don't know that anyone knows the answer. Isn't it a fact or a theory that the reason why you would give hormone therapy in conjunction with radiation therapy is because the tumors become more radiosensitive to the radiation? So if that's the case, other than if the patient doesn't want to, quality of life, why give them the option of you could have it with or without, as opposed to no, actually it works better with, like it does to the prostate?
That's a really good point. And I'm not speaking for or against using hormone therapy in this situation because I offer patients both options and both are considered standard. Again, with a bony metastasis, doing just SBRT or SBRT with hormone therapy are both considered standard options that I present to patients. But why? You're absolutely right. Hormone therapy can make the tumor more sensitive to radiation. That is true. And probably more relevant 20 years ago. And the reason it's more relevant 20 years ago is because 20 years ago, the radiation technology was not as precise, and we were not able to get in as high of a dose as we could today. So 20 years ago, the radiation dose we're able to safely deliver to the prostate is lower than we would like because technology was not as precise. And so with lower than adequate radiation dose 20 years ago with worse technology, adding hormone therapy to make it more sensitive to radiation was more important. Nowadays, the technology's radiation is better. We can pinpoint the prostate better and the bone metastasis better. We can deliver a much higher dose than we could before. And so if the radiation itself can actually just kill the cancer in the bone or whatever, we may not need the hormone therapy to sensitive the tumor because radiation by itself with the dose that we're using is good enough.
In other words, the data that everybody's quoting, no, radiation and hormone therapy works well together, it's outdated based on the technology that you have today?
For some situations, yes. So, in a situation of bone metastasis, with the ability of us to give high dose to the bone metastasis and with SBRT, the SBRT dose to the bone metastasis can probably kill all the cancer in that spot 95% of the time. That dose itself is important, is sufficient, and we don't need hormone therapy to help radiation at all. Not in that situation. There are still situations in prostate cancer where radiation and hormone therapy still work very well together.
And as a primary treatment for prostate cancer?
As primary treatment, yes. For high-risk primary prostate cancer, radiation and hormone therapy, I think, still need each other. But in many situations when historically we're using hormone therapy because radiation dose wasn't high enough, that situation probably no longer exists today.
Amazing. Clavicle is another area that I see where there's bone metastasis. A little bit close to the lung area there, Dr. Chen. Would anything change in terms of hitting the clavicle, the tumor in the clavicle that's a little closer to the lungs?
Yeah, I think as you alluded to, whichever bone the metastasis may be to, in the spine, we worry about the spinal cord, which is critically important.
Yep.
In the clavicle, we worry about the lung, perhaps. In the pelvis, sometimes there could be bowel in the area. With every part of the body, there could be really important normal structure nearby. In 2025, with SBRT, which can really be quite precise, we can never say there's no radiation dose to the lung or spinal cord. But what we can say is with SBRT and the precision we have in 2025, we can really limit the doses to those normal structures and organs to really minimal levels and safe levels that we know to be safe to patients. And so in the clavicle, high precise SBRT, I think the amount of lung that gets dosed to the radiation is pretty modest.
How about the hilar node? Pretty common area that gets hit where you find, and first of all, why is that? So I don't find many other nodes other than the pelvic nodes, and then the hilar node, which is somewhere up here towards, your chest area, a little bit below your thyroid gland and your Adam's apple, as they say.
Yeah.
Any idea why the uptake in the hilar node as opposed to, I don't know, some other node that we have hundreds of nodes throughout our bodies?
Yeah, I don't know why hilar nodes. I mean, clearly, I can explain why the pelvic nodes are most common, because
Yeah.
that's where the
Proximity.
prostate cancer goes through.
Yeah.
Why hilar nodes next? I don't know my anatomy well enough to be able to answer that question, and so I don't know why hilar nodes. But yes, we
So
do
how do we
see.
hit that? So we can hit that again, even closer, perhaps, and maybe I should know my anatomy better as well, but it's even closer to the lungs than the clavicle.
Yeah.
No issues hitting the hilar node with a beam of radiation,
Yeah.
BRT.
Again, I think every patient's anatomy will have to carefully design around the normal organs. Of course, in the hilar nodes, some of the structures that we worry about there, of course, there's lung nearby, possibly the heart,
Mm-hmm.
possibly the esophagus. Those are things that would be relevant in that particular area. Now, I would say my lung cancer colleagues use SBRT to treat lung cancer all the time. It's one of the most effective treatments, SBRT is, for lung cancer. And so there absolutely is technology expertise to be able to treat hilar lymph nodes with radiation and be safe to the patient.
All right. So another situation is positive pelvic node, positive scapula, and hilar node. That's just an example. In other words, more the areas are far away from each other and a couple of nodes, a couple of bones. What's the situation then? What would the patient expect? Do they go in for however many days and they hit all those areas the same day each day? Or is it one area per day? How does that work?
Three very different parts of the body. I think the practice may be different at different hospitals and
Mm.
radiation oncology departments.
Mm-hmm.
In my department, again, we try to keep SBRT to 5 visits or less for the patient. And so there could be, again, let's say it's 5 days total. It's possible that we may treat all 3 areas on a particular day. It's also possible that across the 5 days, maybe we treat 2 areas one day, 2 areas the other day, but we try to keep it within 5 total. I think those are different combinations of possibilities for the patient.
And does it matter that there's a recurrence in multiple spots, 3 to 4 spots, as it relates to the recommendation of ADT? Or that still doesn't change your mind with whether it's maybe yes, maybe no kind of scenario because the beams are better and hot and more dosage and so forth?
I think if a patient, I think one of the earlier scenarios is the patient has only one pelvic lymph node, and that's the only area of disease. This patient now has 3 different areas in different parts of the body. I think for this patient, the expectation has to be set that this cancer probably is in other parts that are probably undetected and maybe
Mm,
in the
mm,
blood waiting to spread to other spots.
mm.
So I would probably counsel the patient on expectations, and I probably would also recommend hormone therapy. Hormone therapy not necessarily to make the radiation work better, but hormone therapy as a way to keep the other systemic disease that's not detected yet, treat that and maybe keep that in check for some time.
And then the $1 million question: 6 months of hormone therapy, 12 months of hormone therapy, 18 months? Where do you like to go? Because shorter better for the patient, or at least, and I have not yet gotten a great answer in terms of why 2 years versus 18 versus 12 versus in 2025, as you mentioned, when the radiation works so well.
Yeah, and there's no right answer there. I think that is still an active area of research. What we have been talking about, I just want to put a term to this, and we mentioned the term oligometastasis, which is when a patient has just a few spots of metastasis. Oligo, a few, metastasis. When a patient has oligometastasis, which is often defined as 5 spots or fewer,
Mm-hmm.
the use of SBRT to treat these spots is still a relatively new concept, maybe only in the last 5 years or so.
Mm-hmm.
We know SBRT for oligometastasis is a very good treatment option for patients. It's effective, it hits those spots with a very high precise dose. But exactly how we use this SBRT framework to add hormone therapy or not, and if we do, how long hormone therapy it is for different situations. There's so many clinical trials trying to answer all those combinations of questions. We don't know right now. It's clearly something that patients need to know, and I need to know to tell what patients are, but we just don't have the clinical trials. Those are ongoing to study those questions.
And there again, to your original point when we first started, it's shared decision making. What matters to you, right? And that's a very important question, because certainly the homogenous perhaps practice that I have, where I see a lot of New Yorkers, but I see a lot of people all over the country. And so far, no one said, yeah, I don't mind being on hormone therapy. I mean, very few people say that. But again, might be people that said, look, if 18 months, 12 months, 18 months, 24 months of hormone therapy, that gets me closer to my goal of, curing this and not dying from prostate cancer, I'm willing to do it. But again, I think it's very important for folks to hear that come armed with good information so that you can have a better conversation with your physician.
I think that's right. I think the other piece I want to add to this is, as we have alluded to in this conversation, there is still a lot of unknowns where we don't have a definitive recommendation for patients.
Yeah.
And in this situation where there's not a right answer, of course, eliciting a patient's preferences is really important. The other piece I think is also really important is the consideration of joining one of those clinical trials that's trying to answer a question, right? If there is a clinical trial where you use SBRT with no hormones or 6 months of hormones, if a patient has no strong preference and wants to contribute to this knowledge to help patients down the line, that's a great option, because without patients joining clinical trials, we would never have answers to these questions.
And we can have more human clinical trials. Everybody complains about, well, these are animal studies. We're not rats. We're not, mice. Well, there's only one way to get that data from human clinical trials, is by humans being in those clinical trials, right?
Exactly.
Finally, unfortunately, there are some times where prostate cancer does metastasize and spread to soft tissue. And that can include the liver, lungs, brain. What's the scenario there with radiation therapy in those types of tissue?
Yeah, I think in the most common situation, if prostate cancer were to spread to the liver or brain, that is often kind of it's very late stage cancer, and the prognosis is not great. I think for many patients where if you have a liver metastasis, the primary recommendation often would be some form of chemotherapy. We can absolutely use radiation, and it is effective. If there is one liver metastasis, a couple of distinct spots in the liver, SBRT is actually commonly used for liver metastasis for all different kinds of cancers that can spread to the liver. And the same thing for prostate cancer if it spreads to the liver. SBRT is a great option to treat liver metastasis. If it were in the brain, SBRT, if it's small and not just all over the place, SBRT is a great option to treat brain metastasis for all kinds of cancers. And it's able to pinpoint at the metastasis, spare a lot of the normal brain, and keep the patient's intellect intact as much as possible. So SBRT is great for metastases in the brain, in the liver, but for those patients, though, in prostate cancer, it's a pretty late stage disease, and you often need some sort of systemic therapy, including chemotherapy.
Wonderful. Dr. Ronald Chen from Kansas University, Department of Radiation Oncology. Ron, final words, and how can people find you?
Well, I think probably the easiest way to find me is just to Google me, Ronald Chen, or Ronald Chen, Kansas, Chen.
Chen. Yeah.
So I think that should be pretty easy to do that. But I am clinically active. I love taking care of patients here in Kansas City, University of Kansas Cancer Center. But final word, early detection, early treatment gives the best outcomes. If a patient were to have a recurrence, catch it early when there's the best options and best chance for cure, potentially before it spreads. But in 2025, the treatment has evolved so much radiation, systemic therapy. There's a lot more hope for patients. In 2030, 35, it'll be even better story then.
That is lovely. And I have to say publicly, I have several patients in the Kansas City and Kansas area, and you've been God sent for me. It feels so good to know that I have a great resource there in Kansas City. So thank you for what you do, and thank you for doing it with the passion that you do, Ron.
Thank you, Dr. Gio. Thank you for what you do to educate the public and teach patients about the importance of this in various different ways. What you do really makes a huge impact.
I appreciate that. Thank you, everyone, for watching or listening to this, I think, amazing episode on prostate cancer. What do we do after a recurrence? Is radiation an option? If so, what kind, and so forth? This is all for you to be armed with the right information so that you can have better conversation and be part of that decision making, that shared decision making. And finally, never forget lifestyle interventions. That is medicine as well. And lifestyle interventions is real medicine as well. When you combine both, it's really powerful. I see it clinically every day. Thank you again for tuning in and for being part of this community. Much love to you all. I'll talk to you next time. Dr. Gio here, signing off.
We hope you enjoyed this episode. You'll continue to receive powerful interviews and insights to support your prostate health journey. For those who want to dive deeper, our exclusive membership offers even more.
If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgio.com. I'll see you next time.